Okay. Hello, everyone. Thank you for joining the session on Sunday afternoon. This session will be recorded, so I hope nobody minds. If you do, just let us know. So the session is about GALS examination, and my name is Devika Verma, and I'm a fifth-year med student at University of Central Lancashire. The learning outcomes of this session. So we're going to talk about a focus history taking, specifically if the patient presents with pain, stiffness, and swelling. And that's because these are the more common symptoms you see in like an orthopedic or MSK related situation. And then we talk about the GALS examination. There will be like questions throughout, and the best way to be interact is just pop down your answers in the chat box. And we'll take some breaks, and if you have any questions, you can let me know as well. Okay, so let's get started then. So we start with the history. If someone's coming with pain, the first thing you do is you do Socrates. You start with the site. Is it localized? And if it's localized, is it in the joints? Is it the bone or a muscle? Or is it everywhere? Is it acute or chronic? Is the character, is it sharp or aching? And is it burning? So that's an important one to make note of, especially in this history. Because if it's burning, you're thinking, is this some kind of a nerve pathology going on? And then if you want to prescribe them any analgesia, your standard opioids would not work. Then you want to go into radiation. Does it travel anywhere? Associated symptoms. So stiffness, swelling, we talk about those two in a bit more detail. Is there any redness? Are they systematically unwell in any way? And those are things like any fever, tiredness, weight loss, night sweats. So you're just covering these red flag symptoms to rule out if there's anything sinister going on. And bowel and bladder function. And that's more important in the context of back pain. And you guys know what's one condition would be suspecting if they had, let's say, bladder or bowel incontinence. You can just open the chat box and pop in an answer. Yeah, perfect. Cauda-equina syndrome. So that's more important if they come in with back pain, but it's always a good question to ask just to see if they're doing fine. Timing, is it intermittent? Is it constant? If it is constant, is it worse in the morning or evening, or is it just a random pattern? Sometimes if pain or stiffness is worse in the morning, it can point you towards certain diagnoses, but we'll have a chat about that. And then, is there anything that makes it better or worse? And you want to assess the severity of the pain. When you're assessing the severity, they say, oh, doctor, it's really bad. It's like a 9 today. Ask them, okay, but has it always been a 9 since it started? Or is it gradually getting worse? Or is it getting better? So you want to see what it was before and what it is now. Okay. In terms of stiffness, there's 3 main things you want to focus on. So firstly, is it there when you wake up? And if it is, how long does it last? So if it's something that lasts for like 5-10 minutes, you think it's more like a mechanical problem. It could be like a sprain, or ache, it could be osteoarthritis, because that only lasts for a short amount of time when you wake up. But if it's lasting for more than 30 minutes, and that's the number to remember, 30 minutes, you're thinking, could it be an inflammatory arthritis? Or even could it be things like rheumatoid, because they have morning stiffness, they have stiffness that's worse in the morning. Ask them, is this affecting your day-to-day activities? And it is to like, what degree is it affecting it? Can you not do them anymore? Can you still manage and push through the pain? And is it better or worse after activity? So the activity part is important, because if it's something mechanical, like a sprain, or even if it's osteoarthritis, if it's either pain, stiffness, or swelling, it would be worse with activity, and it would get better from rest, as opposed to an inflammatory arthritis, which gets worse with rest and is better from activity. So these aspects of the history can actually point you to certain diagnosis and make it easier for you to help the patient. If it's a swelling, you want to see where is the location. Is it warm to touch? If it is, could it be an infection that's going on? Are there any overlying skin changes, such as redness, or things like if it's an obvious fracture or any lumps that you can see? And is this preventing you from doing your day-to-day activities? Following that, if you have time, it's best to go through a systems review, because in like an MSK and orthopedic history, a patient would just think, oh, I've got like a muscle ache or a bone ache. And they wouldn't, if they have any other symptoms, they won't think, oh, how's this related? So why should I tell the doctor this? It could be the opposite way. Patients could tell you everything, but they may not. So it's always good to go through the whole thing and see if there's anything else going on. You go, and then following that, you go through your list of a past medical history, surgical history, drug history, allergies, family history. In terms of social history, you can ask about alcohol, smoking, etc. But some things to focus on is ask their occupation. If they have a job that involves manual labor, they may require sick notes. They may require the employer to make some adjustments. And you may, the main concern may not actually be the pain, but may actually be going to work. And if it's an upper limb pathology, establish which is their dominant hand, right or left, because then you can know how best to support them. And that can also link back to occupation. If it's the right hand is injured, it's a dominant hand. Then you want to ask them, what else can you do for them? Okay, so that's just like a quick summary on the things you need to focus on when it comes to history. Moving on to examination, basic things: perform hand hygiene, PPE in this COVID era, introduce yourself, check the patient details, explain what this examination is, why you're doing it, what you're looking for, and request the patient to be adequately exposed for this exam. In this particular, for GALS examination, you need to ask 3 screening questions. Can anyone guess what they are? Do you know? Just pop them in the chats. So what are the sort of things you want to ask them about? Yeah, okay, perfect. So yes, any pain or stiffness in your muscle or your back, so anywhere in your body, any joints and stuff. Okay. Perfect. So we've got all 3. You guys are doing great. So any pain or stiffness in your muscles and joints. And the reason for asking that is because pain and stiffness is such a common symptom. Then you want to ask, do they experience any difficulty going up and down the stairs? And the reason we're asking up and down the stairs is because, one, we want to see if there's any evidence of a gross motor impairment. And the second thing is it informs you about the patient's baseline mobility. And the third thing you want to ask them is, do you have any difficulty dressing yourself without any help? And the reason for asking this question is you want to see if there's any evidence of fine motor impairment. Okay, so once you've done the basics and you've asked the screening questions, you're going to move on to inspection. So we start by inspecting the surroundings. If it's an OSCE examination, say I'm going to take a step back, have a look at the surroundings. So what sorts of things would you look for in a GALS examination? Yeah, mobility aids. To be fair, like mobility aids is the big one here because you're doing GALS. Other things to look out for is any prescription charts, are there any medications around? But it's just to see if there's anything. So mobility aids are the main one to focus on. Once you inspected the surroundings, then you look at the patient. So the GALS mnemonic is quite handy because then you know what's all the different areas that you need to examine. What's important is that you make sure you inspect each area, examine it before you move on to the next. So for example, if you are looking at arms, you want to inspect them, you want to feel for any abnormalities or any pain, and you want to examine it before moving on to legs. Usually, if you have, let's say, a respiratory examination, usually go through inspection, palpation, percussion, auscultation. When it comes to GALS and MSK related things, your motor changes, so it becomes look, feel, and move. So coming back to arms, you're looking, you want to inspect it, you want to feel, and we come back to what you need to feel, and you want to move and perform certain movements. Once you've done all that, then you move on to the next area. Another important thing to note is that be comfortable in the order you're performing it. So GALS is a handy mnemonic, and you can go in this order: gait, arms, legs, spine. But for example, I personally like to go with gait, spine, arms, and legs. So whichever order you're most comfortable with, which helps you remember the examination, go with that. Okay, so we're gonna start with Gait. And first thing we're gonna do is look. So ask the patient, could you please stand up and just observe? See the general body habitus. Are there any obvious scars or muscle wasting? Do they look comfortable on standing? Do they need any support while standing? Are there any obvious amputations that you can see? Feel is not relevant in the gait, but in terms of move, there are three main things you're looking for. So first is stability, especially on turning. So are they able to walk comfortably? Do they fall or do they need some support? And especially while turning, because sometimes patients can get like a bit dizzy when they turn. So you want to see, is there something going on there? Symmetry while walking. So while they're walking, is their gait or their leg falling to one side or another, or are they able to walk comfortably? Smoothness. So again, are they able to take good steps and walk one foot in front of the other comfortably? Or example, if it's a shuffling gait in Parkinson's, so then it's not going to be as smooth as a healthy individual with a healthy gait. The way I like to remember it is 3 S's, and that's why I've highlighted it. So I've got a question now for you guys. What does this X-ray indicate? Just pop down the letter of the answer you think is correct. Yeah. Okay, perfect. So we're getting the correct answer. The answer is A. So as you can see highlighted here, this is a deformity which we refer to as genu-valgum. More easily, you can refer to them as knock knees. So yeah, so that's normal. That's what we saw in the X-ray, and that would be the other abnormality, which would be varus. The other options I gave here is talpus, valgus, and varus, and those basically refer to clubfoot. And that's how they would look like if they were present. You commonly observe them if it was like an infant, you'd pick it up at that point. Okay. And another question for you guys. Which nerve innervates the gluteus medius and the gluteus minimus muscle? Yeah, not perfect. So the superior gluteal nerve, that's correct. The gluteus maximus is innervated by the inferior gluteal nerve, and the rest of the muscles are not relevant in terms of the gluteus muscles. So why is it important that we're asking that I brought up the superior gluteal nerve? So when you're in a standing position, both the muscles, the gluteus medius and minimus contract, and when the contralateral leg is raised. And then eventually that stops the pelvis from dropping on the opposite side. If your superior gluteal nerve was damaged, you'd have muscle weakness of the medius and minimus, which would lead to an unsteady pelvis. And then you could see a Trendelenburg's sign, Trendelenburg's gait. And that's basically an abnormal gait, which leads to dropping of the pelvis on the contralateral side. So I've got a video for you guys, and it's basically going to show you different types of gaits and the abnormalities. So I request you to focus on the gaits and how different abnormal gaits look like. They have sort of briefly also touched on etiologies and stuff, but it's not an exhaustive list. So don't focus too much on that.
Common. Parkinson's gait is the most common and is caused by dopamine deficiency. It presents as shuffling gait with difficulty in turning around. Some might even call it magnetic gait, because your feet never really lift off. An early sign of the disease is arm swinging while walking. Antalgic gait is also pretty common, and it's caused by pain, usually in one leg. The patient would avoid bearing weight on that leg, so presents with short stance phase. Common causes include fractures, infection of the joints, maybe osteoarthritis, and etc. Waddling gait is due to weakness of bilateral gluteal muscles. This will cause instability of the pelvis, and the patient would waddle from one side to the other while walking. Common causes include muscular dystrophies or muscular diseases, pregnancy, and etc. Just think of something that would damage bilateral muscles at the same time. Trendelenburg gait, however, is due to damage to one gluteal muscle on one side. So waddling is due to bilateral damage, and Trendelenburg is due to unilateral damage. In Trendelenburg gait, the pelvis is unstable, and it will drop or tilt with every step. And medical mistakes is the most common cause. When giving the patient gluteal muscle intramuscular injections, give the injection in the superior lateral quadrant of the gluteal muscle to avoid causing Trendelenburg gait. All right, guys, that's everything I've got. Hopefully I made this easier for you.
Okay, so hopefully that would just give you an idea of what different kinds of gaits would look like. So once we examine the gaits, we'll move on to the spine, and we'll start with look first. So when you examine the spine, you want to examine from the front. You just want to examine the chest from the front, and then from the sides and the back. I've put an image there and I've written A. Can anyone guess what A is? Okay. Yeah, that's perfect. So it is scoliosis. So it's basically an abnormal curvature of the spine. Other things to look for, you want to just see the general posture. Are there any scars, any deformities, muscle wasting, any erythema or bruising? One thing you'll note when you do GALS examination, MSK related, it's in terms of inspection, you'll be looking at very similar things in all the different areas. Okay. And when you come to feel, so you want to start by feeling the spinous process. So you want to start all the way from the top and go all the way down to the lumbar spine. And you're trying to just see, is it aligned? Can you feel, are there any deformities? And is there any tenderness? Particularly if there's any tenderness in the thoracic region, that would be a red flag and you'd be concerned about it. Then when you come down, all the way down, you want to also feel for the sacroiliac joints, and you're feeling for similar things, any pain, any deformities. And then lastly, you want to feel the paraspinal muscles. And here you're just seeing, is there any pain? And can you feel any lumps or any bumps around the areas? And paraspinal just means you're going to go on either side of the spine and have a feel. Okay, an important aspect that was mentioned on the chat by Mr. Sinha is that in an exam, you should know how you can check the Trendelenburg's gaits and do the test. At least you can offer it so the examiner knows that you're looking out for that. Why the thoracic spine, its tenderness is a red flag because it's not a common area to get like an injury. So you can get arthritis but not an injury. So when you get it, you're thinking is it could be a malignancy that's going on or something sinister that's caused pain in this area. Usually if someone comes in with back pain or any mechanical pain, it will be in the lumbar region. And if they've been in an accident, you'd think cervical. But thoracic spine is not that common. Okay, so once you've done look, feel, let's move on to move. So patient's going to be standing in front of you. First movement you want them to do is look up at the ceiling and then ask them to look down on the floor. And with this movement, you're testing the cervical spine flexion and extension. Then you want to ask the patient to try and touch their ears to the shoulder. So please keep your shoulders steady, don't move your shoulders, and try and touch your ear on either side. And with this, you're testing the lateral flexion of the cervical spine. So in an examination, OSCE examination, Instead of describing each movement, just stand in front of the patient and say, can you please follow my movements? And that will make it much easier for both you and the patient. Then you want them to ask them to open the jaw and move it side to side. With that, you're assessing for the TMJ range of motion and if there's any pain. And the next, you want to ask the patient, ask the patient to cross the hands and move side to side. For this movement, your patient can either be sitting on a chair or they can be standing, and you can stand behind them and just place your hands on their pelvis to keep it steady, and then ask them to move side to side. The reason for holding the pelvis or making them sit on a chair is just to make sure that when you're testing the movement, it's of the spine and not of the hips as well. So that's why you want to keep it steady. And with this movement, we're basically assessing thoracolumbar rotation. Okay. Next, you want to ask the patient to slide one hand down the lateral aspect of thigh. And you're checking lateral flexion of the lumbar spine. Make sure you repeat on opposite side. And the next part of the examination, you want them to try and touch their toes without bending their knees. So for this part, you want to place your fingers at two adjacent lumbar spinous processes. Make sure you warn the patient and tell them that you are placing two fingers so that they have an idea of what's going on. So you place them at the bottom before the patient has bent down. And then as they bend down, you want to see like a symmetrical increase. When they come back up, it should come back to its normal position. And that's you testing the lumbar spine flexion. In terms of extension, when they're back up, just stand behind them and just tell them to slightly move backwards so you can see the extension. Okay. So we've got a question for you guys. You've got a 20-year-old who complains of increasing stiffness of his lower back and hips in the morning for 6 months. Associated with tiredness and occasional blurring of vision, there is no history of an injury. What is the probable diagnosis? Yeah, perfect. So C. And the reason why we're thinking of ankylosing spondylitis is because A, of the age, it's a 20-year-old. They've come in with increasing stiffness of the lower back and hips, which is in keeping with ankylosing spondylitis, and it's worse in the morning for 6 months, so it's something that you would expect from AS. They've also got tiredness and occasional blurring of the vision. So ankylosing spondylitis can have like a very wide range of other symptoms apart from orthopedic MSK. They can cause eye problems like blurring, uveitis, and they can cause tiredness, weight loss, etc., and other conditions as well. No history of injury is good because then that helps us rule out the fracture of the spine. Infection, there's no indication of them being unwell in terms of having an infection or fevers or stuff. TB, it's always good to keep in mind, but there's no indication here of any place, of any endemic region where TB could be prominent, and it's quite long going, and the history is more in keeping with AS. Okay. So in terms of after each sort of area, I've made a small table for you guys, which just says what are the things you're looking for, the things you're feeling for, and the movements that you're going to ask the patient to do. So the gait one was quite succinct, but I've done it for spine, and it'll follow after arms and legs as well. Okay, so we're going to move on to arms. We've done the screening questions, we've had a look at the gait, we've had a look at the spine, and now we move on to arms. So again, let's start with look. Okay, so what do you guys think is A? What abnormality, if any, can you see in A? Okay, yes, I mean, someone did say rheumatoid nodules, but we're more, if you focus here, you can see Herbert's and Borchards nodes. So Herbert's in the DIP, and Bouchard's in the proximal. Does anyone know which condition is associated with Herberdin's and Bouchard's? It's not rheumatoid. Yeah, osteoarthritis, perfect. So that's the one for A. What about B? Can you guys notice anything? Yeah, so it's thenar eminence wasting. Okay, so we covered that. So when it comes to looking for any abnormalities, you want to see is any muscle wasting, is there any deformities? It could be anything. It could be rheumatoid nodules. It could be anything. Any swellings, any erythema, any scars. When it comes to feeling, so you want to gently squeeze the metacarpophalangeal joints, and that's how you would do it. Hold the hand, squeeze it, and check for any pain. Always good before you're checking for pain in this movement, ask the patient, do you have any pain in your hands or in your shoulders? So that if they do, when you're performing some movements, you can be cautious with it. And in the second picture, this appearance is also sometimes referred to as an A-band, and that might make it easier to remember it. Okay, moving on to movements. The first thing you ask the patient to do is, can you please place your hands behind your head? And with this, you're trying to assess the abduction and external rotation of shoulder. Then you want to ask the patient to keep the elbow at the side bent to 90 degrees. So you want to start with a neutral position where the elbow would be here. And then that's 3 movements. The first movement is ask the patient to touch the shoulders. With that, you're testing elbow flexion. Then ask them to bring the arm straight down all the way here. And you're testing for elbow extension. And then the third one is, while they keep the elbows at 90 degrees, ask them to bring their palms up for supination and palms down for pronation. Okay, then you want them to make a prayer sign and a reverse prayer sign. With that, you're just testing wrist flexion and extension. Next, ask them to hold the hands out, make a tight fist, and then extend their fingers. With these movements, you're testing finger extension and flexion, and also the general power grip. And then you want them to ask them to touch each finger with their thumb. And you're basically testing any precision grip. And lastly, you want them to hold their hands out. Ask them to squeeze your index finger. Test them both at the same time so you can compare and see if there's any weakness in one or the other hand or arm. And here you're assessing the strength of your power grip, looking for any weakness. Is it equal on both sides or not? Okay, so that brings us on to another question. You've got a 21-year-old student who's complaining of tingling in digits 4 and 5, which is worse than elbow flexion. What nerve is most likely to be implicated? Yeah, perfect. So E, so here you're thinking about the ulnar nerve. A 21-year-old student might be writing that could be one of the mechanisms that might have caused this. Tingling in digits 4 and 5. 4 and 5, thinking what nerve innervates this? That's the ulnar nerve. And tingling, paresthesia, these things can be expected. Worse on elbow flexion is quite commonly observed. If it is a compression of the median nerve, what syndrome would you guys think of? Yeah, carpal tunnel syndrome. So that's perfect. And that would be, so it wouldn't be digits 4 and 5, it would be the other half then you're thinking of. Okay. So that concludes arms. You've had a look, you've felt for any pain, and these are the movements that you would ideally do to check for any abnormalities. Okay. So the next part of the examination, you're going to be assessing the legs, but you want to ask the patient to lie flat. So you want to face them supine, facing up. Make sure they're comfortable lying down flat. If they're not, then keep them as flat as they can possibly tolerate. So let's start with look again. What do you think A is? Yeah, it's a callus. That wasn't very tricky. What about B? Oh, sorry, I put down the answer. Yeah, so A is a callus, B is spitting edema. And other things to look out for is there's any erythema, any scars, deformities, skin changes, or ulcers. And you're just trying to see if there's any abnormalities that you can pick up on, and if it is it contributing to what the patient's presenting with. Then you want to feel. So like in upper limb where we gently squeeze the metacarpophalangeal joints, here we're going to gently squeeze the metatarsophalangeal joints. And again, we're checking for any pain. Always again ask the patient, do they have any pain in their foot or anywhere in the leg? So you can be cautious about it. So in terms of leg, yeah, it's still look, feel, and move, but you also have to specifically examine certain things in the knee. And that's why I've written a subsection as knee here. So firstly, you just want to check the temperature. Compare both sides as you go down. See, is it swollen? Is it warm? Is it just normal temperature? And the next thing you want to perform is a patella tap. We're checking to see if there's any fluid going on there. So how you do this is basically a bit high up on the thigh. You want to place your hand, apply a good amount of pressure on it. And while keeping pressure, you want to bring your thigh up just above the knee, the bump of the knee there. You stop there, and then with your other hand, you want to tap below where the patella is and see, can you feel, it's quite a distinct tap, you can feel if there's any evidence of fluids. And that's how it would look like. So you start from there, put good amounts of pressure, stop, and then tap here and see if you can feel it. And you're just checking see if there's any evidence of effusions. And don't forget to apply pressure so you can actually bring the fluid down. The reason for putting the pressure here is that if there's any fluid, it will come down and accumulate down here so you could diagnose it. Okay, moving on to move. So you want to place one hand on the patient's ankle, the other behind. So you can place it behind the knee, you can place it on the knee, wherever you feel comfortable and you get a good grip and the patient's comfortable. And with that, you want to bring it up, so flexion, bring it back down. You're checking the extension of the knee. Also, if you place your hand on the knee, you can also feel for any crepitus. And then the next part is, again, you want to keep the knee and the hip flexed to 90 degrees. As before, you place one hand on the ankle, one behind or on the knee, and you're checking internal rotation of the hip and external rotation. So the internal rotation is when you're going to move the leg outward, as you can see, and it's in the green. And basically, if you just move the leg on the opposite side, you're going to be testing for external rotation. Okay, so I've got a short video, and I'm only going to play the lower limb part because I feel like that's, you might be able to better grasp the movements with the video. It's only going to be for about a minute.
So I'm just going to move your legs now. Just relax and let me know if you have any pain. So I'm going to start by lifting your leg. And the same on the other side. I'm going to lift your legs up again and turn your ankle out. Good. And the same on the other side. I'm going to test for fluid around your knee now. I'm just going to push down and press lightly, okay? I'm going to squeeze your feet on both sides. Let me know if it's painful. Can you now just touch your ear to your...
Okay, so hopefully with that, it would give you a better idea of how to go about with the lower limb movements. Okay, so that brings us on to our next question. And I think it might be one of our last ones. You've got a 71-year-old male who presents with shortening and lateral rotation of the right hip following a fall outside the grocery store. What is the most likely, given the most likely diagnosis, what is the blood supply to this area? Yeah, perfect. So it's a medial and lateral femoral circumflex arteries. And what diagnosis are you guys thinking of? Yeah, a neck or femur fracture. So the shortening and lateral rotation of the hip is a classic sort of presentation of a neck or femur fracture. And you're worried about these arteries as it can lead to avascular necrosis. The lateral alone would not be, so the medial and the lateral together is what you're concerned about. And the rest of the arteries do not play a role in this. Okay, so in terms of the legs, there's not many movements. You've had a look, you felt, so you're feeling the MTP and you're also feeling the knee for temperature and the patella tap. And then you carry out knee flexion, extension, internal, external rotation of hip. And that brings us on to the end. So in GALS, remember, look, feel, and move. It's the GALS mnemonics quite handy because then you know each area that you have to go through and if you've been through them or not. Once you've done the examination, don't forget to summarize. Situation, so you want to say your name or your role. If it's an exam, you wouldn't have to repeat it, but if it's in the hospital or GP, you'd want to introduce yourself. Give the patient details and give a brief line like this patient's coming with back pain or this patient's coming with something else for 1 to 2 days. Then you want to go into the background. Do they have any other problems? Have they been in hospital before? And is their previous admission relevant to the presentation they're coming with? Your assessment, examination, investigation findings, if there are any, and the recommendation. What are your next steps? What are you concerned about? So I've got a try and SBUS or scenario for you guys. You can have a read through that, and if you guys want to have a go, just switch on your mic and you can try. I won't force anyone. If you don't want to, I can have a go. You've got Joanne Smith here, who's a 72-year-old female. She's coming to general practice. History of osteoarthritis and high blood pressure, and she's presenting with hip pain. On examination, she's comfortable at rest, is using a walking stick when it rains, painful internal rotation and flexion. Rest of the examination is unremarkable. So I'll give you a minute. If anyone wants to come forward, that's perfect. If not, that's fine as well.
I can have a go.
Yeah,
Someone in the chat.
oh, perfect. Yeah, go ahead.
So I met a 72-year-old female, Joanne Smith, who presented to the GP with osteoarthritis. Oh, sorry, no, hip pain, with a past medical history of osteoarthritis and hypertension. On examination, it's unremarkable, and she's got a mobility aid as well, and she experiences painful. Sorry, she feels pain during internal rotation and flexion, but she's comfortable at rest.
Good. Your recommendation?
Recommendation, is that like investigation or like management?
Yes, it's management. It's the next steps. So it could
Oh man.
an investigation would be a next step.
So probably like analgesia for the pain.
Yeah, that's
I'm not sure what else. Sorry.
that's perfect. So actually that was good because you started with the situation, said her name, said she's come to the GP and what she's coming with hip pain. Her background perfect. You mentioned osteoarthritis and high blood pressure. And in terms of the examination, so each one's different. You covered all the main points, and that's what matters. I would have started just saying she's comfortable at rest, can use a walking stick when it rains, and then say the positives first. So she's got painful internal rotation and flexion, so that the person who's listening knows, okay, where this is going or what's happening. If you start with like these parts of the examination unremarkable or rest of it's unremarkable, they may get confused, but that's just a subjective thing. So yeah, as long as you say the positives, and depending if it's an OSCE scenario, I would specify saying no abnormalities in spine, no abnormalities in the arms, or gait. In terms of the lower limb, there was painful internal rotation and flexion, but otherwise it was unremarkable. So in OSCE, I'd give a bit more, just make it a bit more detail so they know. But if it's out in practice, people may not have time and you may just need to make it more succinct. Yeah, recommendations perfect. So the patient in pain, analgesia would be a good shout. If you think you have here it is probably osteoarthritis that's flaring up. If you didn't know the diagnosis, you could have a go and say, I think it could be this. So we could do further tests. If, for example, you're thinking, oh, is it an infection? Your recommendation could be, can we do maybe her basic observations, get a temperature, and can we do some bloods? So your recommendation is whatever that would next step to either help you with the diagnosis or the management with the patient. So, well, the diagnosis here is osteoarthritis, but in terms of the management of osteoarthritis, do you guys know analgesia is good? How else, what are the other options for managing it? Okay. Yeah, so first steps is analgesia, physiotherapy if necessary, and if the patient is overweight, you may also need to ask them to do lifestyle changes, as that can put pressure on the hips and the knees. Then following that, you'd go with steroids, injection steroids, and also you want to make sure the analgesia is optimized. And the last resort sort of would be to do a replacement. But that's right at the end when you've exhausted all the other options. Yeah, so in your recommendation, whichever stage you're at, you can, as long as it's feasible, you can say as many things which are relevant to the situation. Okay. So thank you to whoever volunteered. That was brave and that was a good SBAR. That's the end of the session. Our next session will be on A2E assessment. Keep a watch on I think Instagram and Twitter for like the details of that. I would really appreciate if you guys could fill in a feedback form and just take a few minutes and help us understand what we can do better next time. And I've put the link in the chat box, so that'd be really great if you do that. If you have any questions, I'm here and Mr. Sinha's here. And the references are Macloids, Geeky Medics. This is a good document for SBAR, summarizing an SBAR, and all the images have been referenced in the slides. Thank you for attending.